Yes.
And this time, we're talking about the tricuspid valve. And you'll not be surprised, since the tricuspid valve is an atrioventricular valve, then as with the mitral valve, I'm going to introduce it to you in terms of the valvar complex. And if you remember what we said about the mitral valve, you'll know that I'm going to introduce it on the basis the atrioventricular junction, the leaflets, the tension apparatus, and the papillary muscles. But this time, when we think of malformations, I'm going to concentrate on one malformation in particular, and that is Ebstein's malformation. So you'll see, in Ebstein's malformation, as we had in the hypoplastic left heart syndrome, all components of the tricuspid valve are malformed, but still we should analyze it in terms of the valvar complex. So let's start by looking at the junction. Now the junction supporting the tricuspid valve is markedly different from the junction that was supporting the mitral valve. For a start, it is D-shaped. What I'm going to show you is the straight side of the D is directly adjacent to the ventricular septum. Most importantly, the tricuspid valvar orifice is discrete from the subpulmonary infundibulum, and between the two we have the supraventricular crest. And we'll talk about that again when we finish our discussions with considering the pulmonary route. As with the mitral valve, however, it is very rare to find a discrete fibrous annulus supporting the leaflets, and that again is why I prefer to consider the valve in terms of the junction rather than the annulus. And in the tricuspid valve in particular, it is fibrofatty tissue that produces the insulation between the atrial and the ventricular myocardium. So, if we look at this picture, again prepared very nicely by Diane Spicer, it's a cut across the parietal right atrioventricular junction. There you see the hinge of the leaflet of the tricuspid valve. There is the atrial vestibule and the crest of the parietal wall of the right ventricle. And what you can see is the inferior atrioventricular groove and the tissues that are insulating the atrial from the ventricular myocardium are fibroadipose tissues. There is no annulus supporting the leaflets of the tricuspid valve. Instead, they are hinged within the junction. And here we're looking down on the junction from above, having removed the walls of the atrial chambers. So there you see the right junction, and we can now compare it with the left junction. And we can note that the two are separated by the atrioventricular structures. But now we're thinking about the tricuspid valve. So let's concentrate on the right atrioventricular junction. And immediately now you will see why I call it a D-shaped junction. At the top of the left-hand wall of the D, as we look at it from above, we find the membranous septum, and separating the D-shaped junction from the mitral junction, we have the atrioventricular separating structures, and this is a muscular sandwich. And if we lift away the wall of the sandwich, we find the inferior pyramidal space. We don't have time to talk about that today, but it's important to know that there is an extension of the inferior atrioventricular groove that separates the floor of the muscular sandwich from the crest of the ventricular mass. But we are concerned with the junction itself. And you'll note that the larger part is guarded by the anterosuperior leaflet. To the septal side, we have the septal leaflet, and that marks the straight side of the D. And then the junction is completed inferiorly by the part of the junction supporting the inferior leaflet. So when we describe those leaflets, they are positioned septally, anterosuperiorly, and the third leaflet is inferior or mural. It is not posterior. If we open out the leaflet, the valve rather, we can see those leaflets very nicely. We're looking now at the junction from behind. So there you see the dominant anterosuperior leaflet. I've spread and lifted up the wall, so now I've changed the leaflet that is normally positioned inferiorly to a superior position, but it is a mural leaflet. There is the third leaflet, which is septal. We can see the true arrangement much better if I show you a view of the base of the ventricular mass as viewed from the apex. So this parallels the short axis arrangement as you would see it in the left anterior angiographic projection. And so you'll recognize the left atrioventricular junction. And as we've already commented, that is adjacent to the aortic root. So our attention now is on the right atrioventricular junction. So let's blow that up. And now we see that separating the aorta from the right atrioventricular junction, we have the membranous septum. But we're concentrating on the leaflets, and one is adjacent to the septum, and that is the septal leaflet. And you see now that this third leaflet is truly inferior. It is not posterior. It is hinged from the diaphragmatic surface of the atrioventricular junction. And there is the third dominant leaflet, which is anterosuperior. And that is important in terms of the way the valve functions. Because since the junction itself is D-shaped, the skirt of leaflet tissue comes together in trifoliate fashion. And so it's entirely appropriate that we call this the tricuspid valve. Many will tell you that the skirt has 4 or more components, but irrespective of that, when the valve closes, it closes in trifoliate fashion. And that is in distinction to the mitral valve, which closes in bifoliate fashion. More importantly, it's in distinction to what we see when the valve is malformed in the setting of Ebstein's malformation. And that is why the function of the valve is of such importance. So let me emphasize again, when the tricuspid valve is normal, it closes in trifoliate fashion. And those leaflets are supported by papillary muscles. There is a prominent anterosuperior muscle, a very characteristic medial muscle, multiple attachments of the septal leaflet, but the inferior muscle is itself variable. We can see those two characteristic muscles particularly well in this dissection that was made by my other friend and colleague, Damian Sanchez-Quintana. So Damian has opened the heart from the front and spread the parietal wall to show you the infundibulum. We're going to discuss that very shortly in the setting of the pulmonary root. And we can see it continues as the supraventricular crest, which interposes between the leaflets of the pulmonary and the tricuspid valves. There is the characteristic structure on the wall of the right ventricle, the septal surface of the right ventricle, that we call the septomarginal trabeculation. And it continues towards the apex, where it gives rise to the moderator band. And arising from the moderator band, we have the prominent anterior papillary muscle. The other characteristic muscle arises from the caudal limb of the Y of the septomarginal trabeculation. That is the medial papillary muscle, also known as the muscle of Lancisi or the papillary muscle of the conus. So that is the normal valve. I've emphasized the normal anatomy because I now want to put that into the context of the most important malformation of the valve, which is the one initially described by Ebstein. And if we are to understand the anatomy of the malformed valve, we need to put that into the context of the normal valve, and here its function is just as important as its structure. We need to consider the relationship to the valvar dysplasia, and I'm going to introduce you again to abnormal segmental combinations. And we should remember that Ebstein's malformation can be associated with several other malformations. But it would be inappropriate if we didn't consider the malformation in the setting of Wilhelm Ebstein himself. He was born in 1836 in Prussia, but he was educated in Breslau, which is now Wrocław in Poland, and then subsequently in Berlin. His initial appointment was in Wrocław in 1861, but in 1874 he was appointed as professor of medicine in Göttingen, and he spent the rest of his career in Göttingen, dying in 1912. But it is because of Joseph Prescher that we remember Wilhelm Ebstein. Joseph was 19 years old, and he was admitted to the hospital in Wrocław on June the 28th in 1864. He was complaining of shortness of breath, multiple palpitations. He'd had these problems since a child, and he was blue, his heart was big. The heart was full of murmurs, and sadly there was little that could be done at Joseph for that time, and he died shortly after admission on July 6th. Wilhelm Ebstein conducted the autopsy, and the pictures of the heart were drawn by Dr. Weiss. And this is the picture of the inlet aspect of the malformed valve, and you see there is a remnant of the septal leaflet. There is a connecting tongue between the inferior leaflet, the anterosuperior leaflet, and the valvar orifice is in a very unusual place. And Dr. Weiss also pictured that from the infundibular aspect, where we see that remnant of the septal leaflet, and we note that the anterosuperior leaflet has marked linear attachments. And here is the characteristic feature. The valve no longer closes in trifoliate fashion. The valve has become a bifoliate structure. And that is because of the abnormal hinging of the septal and inferior leaflets. The predominant leaflet remains the anterosuperior leaflet. And in this heart, the inferior leaflet is plastered to the parietal wall of the ventricle, as is the septal leaflet losing its attachment at the atrioventricular junction. As in the heart of Joseph Prescher, in this particular example, there is again a connecting tongue between the septal and the inferior leaflets, but there is a grossly abnormal location of the valvar orifice. It is no longer at the atrioventricular junction. Instead, it is formed at the junction of what we can now call the atrialized inlet component with what is the functional right ventricle. Now, we studied the location of the valvar orifice in a work I did now over 25 years ago with Christian Schreiber, who sadly passed on, a wonderful cardiac surgeon who died far too early. But in this important work, which we conducted at the Brompton Hospital, Christian studied 23 autopsied hearts and showed that the abnormal orifice was rotationally displaced. We know that when you see it echocardiographically, you think it was downwardly displaced, but in reality, it is rotational displacement from the inner curve. And I can show you that particularly well in this beautiful example of Ebstein's malformation. And there you see the anterosuperior leaflet, the conjoined inferior and septal leaflets. And you note now, in particular, the rotational displacement, giving us a bifoliate valve. And when we look at that valvar orifice, then as in the picture of Joseph Prescher's heart, we see the keyhole that is pointing directly into the infundibulum, with now the valve closing in bifoliate rather than trifoliate fashion. This has significance for the echocardiographer because you may not see the leaflets in four-chamber cuts. So here is a heart with Ebstein's malformation that we try to replicate the four-chamber cutting, and you see that it seems that the atrioventricular junction is unguarded. We can look at the atrialized inlet, but when we look at the anterior part of the heart, there is the valve, and it is between the atrialized inlet and the functional right ventricle. But there is marked variation also in the attachments of the anterosuperior leaflet. So here you see an anterosuperior leaflet with focal attachment. And note that as in the heart of Joseph pressure itself, there is deficiency of the septal and the inferior leaflets. Much more frequently, we have that connecting tongue in this instance with an orifice looking into the infundibulum, but also with multiple fenestrations or hyphenations in the attachment of the conjoined anterior and inferior leaflets. In this example, there's a much more linear attachment, again, as in the heart of Joseph pressure, now with the keyhole pointing into the infundibulum and marking the junction between the atrialized inlet and the functional right ventricle. Rarely, that keyhole can be blocked, giving us an imperfect valve. And now the functional right ventricle, as you see here, is with its outlet component is fed through a ventricular septal defect. And this is the key to surgical variation, the distal attachment of that anterosuperior leaflet. And there is a spectrum from the variations I've shown you, the focal attachment, the hyphenated attachment, the linear attachment, ending up at the imperfect valve. And I think it is much too artificial to try to divide that into types A through D. But these features are particularly important now as you consider which patients are suitable for a cone repair. Oftentimes, the leaflets themselves are dysplastic, and they are dysplastic in this valve. But in this valve, the dysplastic leaflets are attached at the atrioventricular junction. So this is not an example of Ebstein's malformation, although the leaflets usually are dysplastic when we do have Ebstein's malformation. Now, all the hearts I've shown you thus far have had concordant atrioventricular connections. But when I was talking about the mitral valve, I pointed out that on occasion, the left-sided valve can be regurgitant when it is a morphologically tricuspid valve with discordant atrioventricular connections. And most usually, that is the consequence of an Ebstenoid malformation of that left-sided morphologically tricuspid valve. Very rarely, the morphologically mitral valve can show Ebstein's malformation, which is one of the lesions I did not describe when talking about the mitral valve, but it can exist. Don't forget the associated malformations. Almost always, patients with Ebstein's malformation have a coexisting atrial septal defect. On occasion, they can have a ventricular septal defect. And it can be a particular problem when the malformation is associated with pulmonary stenosis or atresia, made worse by Wolff-Parkinson-White syndrome. But the bottom line, the leaflet itself, the junction itself is rotationally displaced rather than downwardly displaced with involvement of those septal and inferior leaflets. And as a consequence, the valvar orifice looks from the junction of the atrialized inlet directly into the functionally right ventricle and usually is seen as a keyhole. But the major surgical variation involves the anterosuperior leaflet, and oftentimes that is also abnormally muscularized. Remember, the malformation can be frequent with congenitally corrected transposition, but do not forget the associated malformations. So I've concentrated on Ebstein's malformation because that is the most important lesion involving the tricuspid valve, but hopefully that sets the scene now for the ongoing discussions. Thank you.